Please welcome back your host, Tony Militello.
Welcome back, and thank you again for joining us for this next two sessions. It's now my extreme pleasure to introduce Richard Fairfax, who will be presenting on an OSHA update today. Richard Fairfax, who is a certified industrial hygienist, retired in 2017, joined the Occupational Safety and Health Administration, or OSHA, in January of 1978 and retired in 2013. At OSHA, he was a practicing field industrial hygienist and the deputy director and the director for enforcement programs. In 2008, he was the acting director of construction, and in 2010, Mr. Fairfax was designated as the deputy assistant secretary overseeing all field enforcement and training operations for OSHA. From 1993 through 2010, Mr. Fairfax wrote an industrial hygiene column entitled OSHA Compliance Issues for the Journal of Occupational and Environmental Hygiene, and he still serves on the editorial review board. Currently, Mr. Fairfax works part-time for NSC as a principal consultant. Again, without further ado, an OSHA update from Richard Fairfax.
Great, thank you. And I hope you can all hear me. What I'm going to do in the next half hour is kind of just give you an overview of what OSHA is up to in regards to COVID and a little bit what they're planning. We're going to talk about their guidance documents. We're going to talk about enforcement, of course, and then we'll talk about the standard setting process. So turning first to the guidance document, this slide and then the next slide I put up are, in my mind, the key guidance documents. If you go to OSHA's webpage and you look up COVID or you look up COVID guidance, or you just go on and Google COVID guidance from OSHA, you're going to get a lot of materials. And the agency's obviously been very busy, the last two plus years. But the problem is a lot of the documents are archived. A lot of them are outdated, but they're still up there. And, a lot of them are not a lot of them, but a few of them are probably a little bit incorrect as things have changed. So one of the questions I get from NSC members and others are, what are the key documents? So this slide and the next slide are, in my opinion, if you're looking to see what OSHA is doing, if you're looking to see what OSHA is enforcing, these are the key documents. And the first one up there was issued in June of 2021. And it was issued in conjunction with the issuance of the emergency temporary standard for healthcare. So this is actually quite a good document. It's whenever OSHA issues a standard, they follow it up with a compliance directive that basically tells everyone OSHA's expectations and how to interpret the standard. So this is out there. When OSHA does come out with the final new standard for COVID and healthcare, this directive will be updated. But right now it's still up there and current. Right after, in 2020, when COVID got going and OSHA took, kind of a leading role on the workplace safety and health side of that, OSHA issued a national emphasis program, which is an enforcement targeting system looking at COVID. It's been updated a few times, but the last update was in July of last year. And in that national emphasis program, OSHA set an inspection goal of 5% of all of their total inspections would be tied in one way or the other to COVID, whether that's a targeted inspection or a complaint, a referral, a fatality, whatever. A little bit unusual, and I think OSHA did it because so many of the state plan states had initiated their own COVID protocols on enforcement, is that the states were encouraged to adopt it. Normally, it's a mandated process whenever OSHA issues a national emphasis program, but in this case, it was encouraged. Also in July of 2021, OSHA issued what they called an interim enforcement response plan. And there's not much to this document in my mind, but it does lay out what OSHA expects as far as enforcement. And then in March of this year, OSHA launched an initiative focusing on healthcare. It was just a 3-month-long initiative, and went from March 2nd of this year to June 9th of this year. And as of October 11th of this year, they had conducted an additional 1,050 inspections just in the healthcare industry. So these are key documents, and I mentioned the next slide had one. The other key document is a guidance document, and OSHA has done this in conjunction with the CDC guidance documents. This was last updated in August of last year, 2021. So it's old, and some things have changed, some things haven't. And OSHA has said for all along that they weren't going to update this document until the CDC updated their guidance document. Well, the CDC updated their guidance document last August, and OSHA still hasn't updated their guidance document. I know they're working on it, but they still haven't updated it. The link in blue there is, if you haven't seen this document and you have access to these slides, you can click on the link and it'll take you to the document. If you don't, then you can just go to Google and put in CDC COVID guidance, and there'll be a number of ones coming up, but the most recent one, you can go by the date, August 11th, will be there. So why has this taken OSHA so long to update? I think what's happening, I've gotten some indications from talking to OSHA, is that I think, as many of you know, OSHA is at the point of getting ready to come out with a final standard for protecting workers against COVID in the healthcare industry, which we'll talk about later in other slides. So I think, or I believe, what OSHA is doing is waiting. Now that they have the updated CDC guidance, they're waiting until the standard goes out, and then they're going to put out an updated guidance document. Excuse me, which kind of makes sense. So moving on, let's look at OSHA enforcement activity. And OSHA actually has been quite busy. On the enforcement side, from February 1st, 2020, which is kind of OSHA's unofficial date of when they started taking formal action against COVID, through October 16th of this year. So just about a month and a half shy of where we're at now. The agency received 22,632 complaints and referrals related to COVID. That's a huge amount. But of those, OSHA only opened a little bit over 5,400 actual enforcement inspections. And if you're wondering the difference, I think it's real interesting, is that most of these OSHA handled by letter. They didn't go out and do an inspection. And roughly, if you do the math, it's roughly right around 76% of the complaints and referrals OSHA received, they sent a letter out on it. And only about 24%, just under just under 25%, they actually did inspections on. So from a complaint and referral response, OSHA is actually doing, handling most of the COVID-related complaints and referrals by letter. The thing with OSHA is, if you get a letter or you get an email or something like that saying they have a complaint, you do have to respond to it. If you don't respond to it, then OSHA is going to come out and do an inspection. So I mentioned earlier that OSHA launched a national emphasis program for COVID-19. It's been updated a number of times. The last update was in March of 2021, but as of October of this year, under that national emphasis program, they had opened a little bit over 3,500 inspections. Now, a little bit over 2,700 of those were unprogrammed. So these are complaints, referrals, fatalities, that sort of thing. And under the NEP, they actually only targeted 775 inspections that they call programmed or targeted inspections. The fiscal year goal for 2022 was 5% of their total inspections, which their budget, I forget the number they budgeted, but of that 5%, that would have been 1,593 inspections. The agency actually did, almost 2,400 inspections. So they were at about 149% of their goal. So obviously, COVID has been a key factor in OSHA enforcement. From March to October of this year, they launched a focused healthcare initiative, which is part of the NEP. It's just kind of a sub branch of that. And as of October 11th of this year, they had opened 1,050 inspections in the healthcare industry. And they also had a 3-month initiative earlier in the year, and 12% of the OSHA inspections were focused on COVID over a 3-month period. So obviously, with the focus on the rulemaking for the healthcare industry, OSHA has a direct focus on conducting inspections in that industry, essentially getting the industry ready. I put 2 links in the bottom just for your information. One's on enforcement data and one's on whistleblower activity, because there is a push on the whistleblower front related to COVID, so you can get actual data. And on the enforcement side, that's where I got this data from. So I broke it out. I went in by the NAICS, the SIC codes or the NAIC codes, and I looked at the top 10 industries for receiving complaints and OSHA inspections. And so you have it here. You have the healthcare industry was obviously first with 4,170 complaints and 3,348 inspections. And this data runs from February of 2020 through October 16th of this year. If you're wondering why there's more complaints than there is actual inspections, remember, most of the complaints that OSHA was getting, they were handling by letter and not doing inspection. So that's what is the difference in the numbers. So healthcare was first, followed by retail with 283 inspections and almost 2,400 complaints. Restaurants and other eating establishments, 75 inspections and a little over 1,400 complaints. Construction industry, 564 complaints, 109 inspections. Warehousing and storage, 376 complaints, 31 inspections. Grocery stores, supermarkets, 322 complaints, 149 inspections. Then you can kind of, go down. The interesting ones was the animal slaughtering and processing with 140 complaints and 166 inspections. And then poultry processing with 59 complaints and 53 inspections. Before I started looking at the data, I thought the meat processing and the poultry processing would be right up there under healthcare, because if you recall, on some of the original national emphasis programs and the original focus for enforcement activity, healthcare was first, followed by food processing, meat packing, and poultry processing, and then warehousing. But these ended up much lower on the list, which was surprising. I don't really know why, except maybe it wasn't as big a deal, after the COVID thing got going and the controls started getting put in place and OSHA got going as people thought it would be. But, be real frank, I don't know at this point. So if you look at the violation point, we'll spend a minute going into this because I think it will be helpful to you. So as of October 16th, and again, this is from February of 2020, there were 1,400 violations issued by OSHA, and that does not include grouping or anything like that. It's just straight violation. 739 were serious, 628 were other than serious. So not a big difference between those two. 24 were repeat violations, meaning that the employer was cited previously for this and did not really corrected it, but then didn't maintain the corrections. There were 4 willful, and then there were 4 that are just classified as other. That could be a failure to abate. So when OSHA went back in on a follow-up, the employer hadn't done anything. And the interesting one is 427 hazard alert letters. If you're not familiar with a hazard alert letter, part of the 739 serious violations included a number of general duty clause violations, which is section 5A1 of the OSHA Act. And that is the citation that is issued if there is not a standard. So most of the 5A1 violations or the general duty clause violations related to COVID were tied in with not having a COVID prevention program. The general duty clause quite frankly, takes a lot of documentation to establish, and when OSHA does not have enough information or enough, investigative information to issue a general duty clause violation, what they do is they issue what's called a hazard alert letter, which basically puts the employer on notification that OSHA thinks there's a problem here. And the letter basically says the employer needs to fix it because OSHA will be coming back and doing a follow-up. And if you haven't corrected it, then you'll get the general duty clause violation. So it's kind of a, OSHA found a problem. They didn't have enough documentation to cite it, so they put the employer on notice. And at some point later, they'll go back and check. And if the employer hasn't taken heed and done anything, then they get a citation. So let's look at, we gave you the total numbers of violations. Let's look at the actual number of standards that were cited. And these are ranked from the most cited at the top down to the least cited at the bottom. And I only listed 6 there. There's a few other ones in here, such as 1910-141 for tags, and 1910-141 also for housekeeping and things like that. But the most cited violation was 1910-134 for respiratory protection. And that one, when you look down at the data, it was either for not having a written respirator program when you required respirators. It was not for not doing the medical, or it was not for doing the proper fit testing. Meaning what happened is the employers just, more than likely than not, gave the employees an N95 and told them they were required to wear it, and then didn't do any of the other required material. The next most cited one was record keeping, 1904.4, which is recording COVID cases on the OSHA 300 forms. With the emergency temporary standard, even though it was pretty much stayed, that was the third most cited violation. And most of those violations on this one were tied into deficiencies in the COVID prevention program. 1904.39 was record keeping also, but it's reporting. And it requires for a fatality to be reported to OSHA or any hospitalization to be reported to OSHA. Then 1910-132 for personal protective equipment. And then comes the general duty clause. And that was of the 6 I looked at, that was the 6th most cited violation. Total current penalties for all violations related to COVID was $7.8 million. And that again runs from February of 2020 through about October 16th of this year. This is just a little bit of trivia thing. I wasn't sure where to put in the slide, but I review the literature periodically on COVID and the test results and the variants and things like this. And I came across this interesting fact in the New Science from last month, and it basically said in England and Wales from March of 2020 through June of 2022, there was an excess of deaths due to cirrhosis and other liver diseases, like by almost 20%. And during that same time period, there was an increase in deaths caused by diabetes by about 34%. So, you hear a lot about long COVID, and you hear a lot about, other illnesses and diseases associated or triggered or instigated or whatever by COVID. And this was just a little fact, and I thought it was interesting, so I threw it in the slides. So let's turn to the COVID standard and see where we're at. And just to be clear, the COVID standard will be applying to the healthcare industry, and we'll discuss the healthcare industry in a minute because frankly, it's more than what most people think it is. So it was originally due out, according to OSHA, in September, October of this year. That didn't happen. I have here, I spoke to Doug Parker, a week or so ago, and he thought it would be out in the late fall or early winter. I actually spoke to him a couple weeks ago, so that's a mistake, but it still hasn't come out. and I have learned that the standard is done and ready, and they're just waiting to send it over to OMB, which is the Office of Management and Budget. And any OSHA standard goes over for them to review. They have 60 days to, once they get it, to look at it and provide, the approval or comments back to OSHA. So I doubt we'll see it in the fall, but you never know. But it could come out, before the end of this year or early next year. But the next step is to send it over to OMB for their review. So what is the new standard going to require? So, but first, let's get into it. I mean, and this is just right out of the definition. It says, except as otherwise provided in this paragraph, this section applies to all settings where any employee provides healthcare services or healthcare support. So, and I just, like I said before, I think that's broader. So just what does that include? So healthcare services are really anything where healthcare practitioners, doctors, nurses, emergency personnel, oral health professionals, dentists, and anything else are involved in promoting, maintaining, or restoring health. And some examples include, and this comes right out of the proposed standard, so this will be in the final standard. So hospitals or hospitalization, long-term care, ambulatory care, home health care, hospice care, emergency medical response, patient transport, and then for the purpose of this standard, there's a little note in that says it also includes autopsy services and that sort of thing. So that's fairly broad for healthcare, but it also says it includes healthcare support services, and that's broad. So healthcare support services include patient intake and admission, patient food services, equipment and facility maintenance, housekeeping services, healthcare laundry services, medical waste handling services, and medical equipment cleaning and reprocessing service. So let's just look at two of those. The healthcare laundry service and the medical waste. Those are normally in a lot of hospitals and healthcare facilities are taken care of by third-party contractors that come onto the site, pick up the materials, take them off-site, deal with them. In the case of medical waste, they probably go through some sort of incineration process, but in laundry, they clean it and they replace it. So, so their association with healthcare is that they're coming on site to pick things up and take it off site. But under the standard, they will be covered by the standard. So if you're covered by the standard, and when this new standard goes into effect, I mean, the main point is the third bullet I have down here, and most of the standard is going to be dedicated to having a COVID protection program. The standard will deal with requirements for respirators and personal protective equipment for SIR. It will require for a respiratory protection program, and my guess is it will reference OSHA's respiratory protection standard, was 1910.134. But most of it is going to be dedicated to having a COVID prevention program. So what does that include? There's a few other things, but these are the basic things, and I got it out of the proposed standard. Worker screening, identification and isolation of COVID cases, implementation of a hierarchy of controls. So working at engineering controls first, then moving down to work practice, keeping distances and whatnot, and administrative controls. Establishing administrative and safe work practice controls, personal protective equipment, which we've mentioned, cleaning and disinfection, worker training, and then return to work protocols. The question comes up on vaccinations, and I don't know where. I've tried to get the information from OSHA, and they're being very tight on that, so I wasn't able to get it. But my guess is that it'll be tied in. If the requirement, I think, will not be there to require vaccination, but if people are vaccinated, they don't have to get tested. And if they're unvaccinated, they're going to have to get tested. That's my guess, but I'll be real frank, I don't know that for a fact. So the standard will be coming out shortly. It will deal with COVID prevention and protection in the healthcare industry. So if you're asking, well, what about everybody else? That's going to be kind of business as usual for what OSHA is doing. And that's why that guidance document that OSHA should be updating soon is really important, because it'll go over what to do. So OSHA has existing standards, and they also have the general duty clause. So if you're in a food processing industry, for example, and you have an outbreak of COVID and an employee files a complaint, or you have hospitalizations and you report those to OSHA, and OSHA comes out, OSHA will fall back on existing standards. 1910-132 for personal protective equipment, 1910-134 respiratory protection, 1910-145 for signs and warning issues. I don't have it up here, but 1910-141 for housekeeping and that sort of thing. And then the general duty clause. And like what OSHA has been doing for the last 2+ years, is the general duty clause is going to focus on having, if you have a potential for exposure and you have exposure, then you should have a COVID protection program, which should be covered under the general duty clause. So I wanted to get, in the last just 3 or 4 minutes, a little update, because the biggest questions I get on COVID from OSHA are mostly tied into what's required for record keeping. And I have to admit, it's very subjective, and it's not real solid. But if you do these steps in here and you document it, and OSHA comes in and you have the documentation to show why you didn't record a case, you should be good. So first off, any confirmed case of COVID-19 means that you've had one of the recognized tests that confirms that it's COVID. And OSHA isn't specifying which test or anything like that, but if you have a confirmed test, then there's a potential for a COVID issue. So for work relatedness, what you need to do is basically, if you have a person that comes down to it, you need to talk to the employee and find out how they believe they contracted COVID at work, at an event outside, from a family member, from a friend. You need to discuss the employee's, in his or her out of work activities. Did you go to a concert? Did you go somewhere where there's potential? And then review the employee's work environment for any sort of potential exposure. And like I mentioned a minute ago, document this thing. You talk to the employee on this date. This is what you asked. These are the questions you came up with. And don't worry if you look at it and you record it or you make a determination that it is not work related, therefore not recordable. And then down the road, a week or 2 later, you realize there's an outbreak, and that worker was potentially, received got COVID from the workplace. You can change it. That's reasonable. Just document your rationale. So just a little bit of guidance for, if it is work related. So it's more likely than not to be work related if you have several cases developing among coworkers, and those are all coworkers are working together. The illness is contracted shortly after a lengthy exposure, close exposure to a particular customer or coworker. That's a confirmed case of COVID. Or the job duties include frequent close exposure, to people outside the workplace where there's a potential for transmission. So if you come up with these factors, then it's likely work related. And then counter that, if you only have one worker and no one else around them comes down with COVID, or the job duties do not include, close working relationships or close proximity to other people, and other people that the employee worked with or socialized with, whether it's family members or they went to concerts or whatever, and there was an outbreak there, then what you have is more likely than not that it's not COVID. So again, document. And finally, I was asked to touch real quickly on the executive order from President Biden on any contractors that supply services to the federal government, requiring vaccination. And this is huge. And, last October of this year, the 11th Circuit narrowed the scope of it, but they left it in place. OMB issued a notice on this, and a link to the notice is on this page. But basically what it says is that while this executive order is in place and is in effect, OMB has not lifted the stay on enforcement. So and until they do so, agencies cannot enforce this requirement on their contractors. And the 2 points in this notice says these agencies cannot take any steps or require covered contractors or subcontractors to come into compliance with this executive order, and they cannot enforce any contract clauses from that executive order. So until OMB comes out with a change and says that the agencies can enforcement, this executive order basically is not in place or in effect. And with that, I thank you for your time, and I finished right on time. I have no idea if you have openings or opportunities for questions, but I'm happy to do so. That's up to you folks.
A COVID final standard, but I think that your slide talking about non-healthcare, I think that really addressed that. So with that, I certainly would appreciate everyone giving kind of Richard a round of applause. Was something we heard earlier in Travis's comments during this morning session. People began to wonder when the pandemic began was, well, what does OSHA have to do with it? And really, again, Richard, I know could go on for twice as long, if not longer, but hopefully this last half hour really gave you a synopsis of why OSHA's involvement in the pandemic, why their engagement in protecting the American workforce is so fundamental to protecting that exact workforce. So, Richard, thank you for your time and insights again.
I don't know if there's anything coming in, but I do not hear anything from anyone, so I'm going to jump off.
Sounds good. Great, Richard. Thank you. Now we'll take the opportunity to transition to our final panel for today, talking about mental health, fatigue, and burnout. Again, hopefully everyone is staying with us. Again, been able to be caffeinated and taking all the necessary precautions and hazard controls that they need to make sure that they are fully attentive and present. We heard about that before, right? Being able to show up and be present. We heard Gus talk about that again in this morning session. So we ask you to do exactly that. Show up and be present for this last presentation for today about mental health, fatigue, and burnout. And again, it's my distinct pleasure to introduce to the moderator for that session, Rebecca Martin. Rebecca has 20 plus years of diverse experience in public health and social services, including program planning and systems development, research and evaluation, community planning, and direct service. She has worked extensively in maternal and child health, infant mental health, DEI, and communications. She has served in the United States Peace Corps for over 2.5 years. She earned a Bachelor of Science degree from the University of Wisconsin-Madison and her MPH from the University of Wisconsin at La Crosse. She is bilingual in English and Spanish. And with that, I'd like to introduce and turn the mic over to Rebecca.
I'm just going to go ahead and introduce our panelists. We have David Whitesock. So David is CEO and founder of Commonly Well. He has led innovative and entrepreneurial programs in addiction, recovery, and technology since 2004. While designing new approaches to peer coaching, he developed the Recovery Capital Index, or the RCI. The RCI is a scientifically validated assessment that measures recovery and overall well-being. David founded Commonly Well in 2020 to broaden the reach and impact of the Recovery Capital Index. Through Commonly Well, David also works with healthcare systems and behavioral health clinics to design and implement improved patient experiences. Next, we have Erica Witcherwick. Erica is a health management consultant with Marsh & McLennan Agency, who helps employers create environments that support the health and well-being of their employees. A devoted professional, Erica strives to build health management strategies and a culture of well-being within her clients' organizations. Erica has a passion for sharing her expertise about resiliency, mental health, and creating lifestyle changes that last with employers. With Erica's instructor certification in mental health first aid, she strives to teach others how to support those living with mental health challenges while helping to end the stigma associated with mental health. And our final panelist is Amanda Finnegan. Amanda is a CSP who has been in the health, safety, and environmental field for over 25 years. The majority of her career was in Alaska, providing HSE leadership for oil and gas, construction, and operations and maintenance activities. While she's been a supporter of Jacob's Mental Health Matters program over the last several years, she took on an active leadership role 2 years ago to help better expand the support of our employees during the pandemic. She provides training and support to the Positive Mental Health Champions, which is a peer-to-peer network within Jacobs. She also works to promote their 1 Million Lives program within the Americas. Welcome, everybody. So to kick us off, we are going to start with a first question, and I think we'll let Amanda start, and then everybody else can weigh in as we go. So our first question is, why should EHS professionals be supporting workers' mental health? And how does this tie into physical safety?
Can you hear me okay? Wonderful. Thank you so much for having me today. When asked the question if EHS professionals should be supporting mental health, my first reaction is like, of course. We have so many statistics that are emerging, especially over the last couple of years. They've been quite a bit more detailed about the importance of supporting mental health in the workplace. The statistics about, I think the most recent say 1 in 5 Americans suffer from a mental illness at any given time. Anxiety and depression are the leading cause of disability. The business case for that is, that's over $1 trillion annually on lost productivity. So there is a really strong business case for why you want to support your employees' mental health. As an EHS professional, a lot of the responses I hear from people are, well, that's HR's job, or that's something for operations. But I think historically, a lot of the people side, especially on the health side, the mental health side, a lot of that really was tied back to HR. But both of our professions have been evolving so much over the last couple decades. And instead of just focusing on people or on processes, we're focusing more and more on people. So when we do incident investigations and we come down to the root cause of, the incident was caused by fatigue, distraction, we used to just stop there, but now we dig in deeper and we're finding, people are burnt out. They may be suffering from poor mental health and haven't been able or felt comfortable to seek help. Maybe they don't know what the resources are. So as health and safety professionals, more and more, we're finding ourselves in that realm of what was historically HR, but we need to care for that whole being. So people are more distracted and they're becoming injured because of it. And it's, potentially related back to mental health. So there is a very strong tie, I believe, back to physical safety, where you normally step back and think, oh, am I too tired to perform this task? Well, why am I too tired? Am I burnt out? Am I fatigued? And we're asking those questions more and more. And so for EHS professionals, we really do need to focus on mental health, get more training on mental health. And it's not just operations or HR. So.
And can you explain a little bit more about sort of how we're linking mental health with that physical safety piece for people who might still be struggling with that connection between mental health and employee safety?
Well, there's probably two parts. There's one that, physically stress and burnout and these and poor mental health manifests itself physically. So people can, they're less able to do their jobs physically. They can put themselves more at risk. They're not as productive. So that's one element of it. And if somebody goes out on mental health leave, it's longer than if maybe somebody went out because they ended up with a physical injury. But the other side of it is the direct link where your mental health is suffering and you're not able to perform your job as well. You're distracted and therefore more likely to become injured. So the physical side of it, where there's physical injuries or incidents that happen because somebody's mental health is struggling, because they're distracted, because they're tired, because they're burnt out.
Thank you. David or Erica, is there anything you wanted to add?
Sure. Our mind drives our body. And I apologize. lost my voice yesterday, so I'm just hopefully it sticks with us to this. But our mind drives our body, as Amanda said, and we have to focus on both the internal and the external things that allow us to think clearly, feel clearly, to make the solid decisions, to execute at peak performance, and to execute safely. I want to pick up on some of the statistics that Amanda talked about. We focus in a lot of our work on a lot of the addiction, and addiction is a mental health problem. At the end of the day, it's in your brain. And we typically see that 75% of the people that struggle with a substance use disorder are working. They are part-time, full-time employed, going to work every single day. But on top of that, there's another 30 to 40% of people that are experiencing some form of anxiety and depression. So if we really look at the population, about 10% struggle with a substance use disorder, another 40% of anxiety and depression. That's now half of your workforce that is experiencing some real troubles. And so how we engage in those in terms of inside the workplace is really important. And then finally, there are two places that human beings spend most of their time. One is in bed. About a third of our life is spent sleeping. And the other third is spent working. And so it's really important that we, where we go to do the things that we do, they are optimal environments for us to be the best that we possibly can be. And so the HR professionals and workplaces have a very clear line to support those areas.
Thank you, David. Erica, is there anything you wanted to add?
Yeah, I would love to add something. I want to apologize. I had some connection issues on my computer. So here we are using another piece of technology. But, as we've been talking about this and just listening in, I feel like, something we have to consider is that it's not always HR hearing the needs, seeing the early signs, seeing people struggling. And so we have to really focus in on all of our people. So who is it maybe in the EHS community that might be the people who hear some of these things, who recognize some of these things? And it might be employees supporting each other. And so there's a role throughout the entire organization and a responsibility, I think, for companies to educate not only their leaders, but educate their employees. Because, as it's shared, HR always kind of gets looped into this topic of mental health. And I think that it's not only HR's role, it's everybody's role.
It's a really important point, Erica. What are some things that your company's doing specifically to support worker mental health throughout this pandemic? You mentioned not just HR, but everybody. What are some things that you guys have been working on specifically at your organization around that area?
Yeah, I mean, what a last few years, right? I think, we've been meeting employees' needs in different ways, right? So for my industry and for majority of my team, we had work from home. And so for a lot of people actually didn't have a work from home setup. And that could be stressful. Maybe you don't have the technology that you might need. Maybe you don't have a space to be in. And so I think something that actually helped relieve stress for a lot of people was having a stipend to purchase materials to work from home. It was also working with your leaders, your managers, to have a flexible working arrangement. We know that different individuals maybe had higher impact throughout the pandemic. And so every experience was unique. So having that openness and conversations with your leaders, I think, really helped create strong relationships with employees and their leadership. On top of that, making sure that we give extra reminder of what is an EAP, right? Employee Assistance Program. And a lot of organizations I even go into don't fully understand what that means or what that looks like. So I felt like our HR team did a great job of talking about, here are the variety of ways you can use our EAP. It might not be just this one standard thing that majority might think it is. Some companies rebrand their EAPs for that very reason, because people don't fully understand what that type of resource is. And I think something that was really important was that we had leadership transparency, and we had our leadership talking about their own mental health, talking about racial injustice, talking about social issues, because they knew this was impacting our teams, our people, our ability to work. I felt like that was really important. And to also hear from our colleagues. We actually had an internal event where people volunteered to share their story. So we had a colleague who had a child that was living with a mental health disorder. We had an employee who said, "Hey, I'm going to therapy, and I'm okay to share that with all of you." And we had an employee who is living with a current diagnosis. And they were open in sharing about their story, about how the pandemic has impacted it. And I think that just shows us, again, how real this is, and how it's important that we know more about each other, that we ask questions, and that we seek to understand.
So, what are some things that your company did, or any of the other organizations did, to create sort of a place where that could happen? I know for some people listening, or people going through different things, might be thinking, "There's no way I would be able to do that at my office," or "There's no way I would share that." So, what are some things that happened that allowed that to occur?
Yeah, I mean, I can jump in, and please feel free to speak up, David and Amanda. But I think it has to come not only from senior leadership, but it needs to come from mid-level managers and supervisors and the people we talk to almost every single day. And so I think it's, if you have a plan already implemented, you maybe have safety trainings, right? Usually those are regulated. We have to do those things. Why not take the opportunity sometimes to integrate the topic of mental health, to have the hard conversations? And that's where I think it's a lot of discussion with HR teams and leadership teams, and training for them so that they know the right verbiage, the right way to maybe start the conversation around that, because we know industries can be so different, and language matters. It's really important in this space. But I think that we see it maybe just occur a little bit differently. And we have to find ways to relate mental health to things that maybe they already understand. And talking a lot about physical health and safety, I think, is important.
Yeah, I'll be happy to jump in on that and just say, we're a small company. There's just a few of us, but we work with a lot of behavioral health and provider organizations that are helping other people be well. And one thing that we have found is that when we're talking about behavior change, it's really important, as Emily noted, that you got to have somebody modeling the good behavior. So when you have leaders showing up, doing the things that you want the rest of the team to do is really important. So one of the things that we do to model the way that we care for ourselves and the way that we show up to the people whom we serve is we have some pretty relatively strict rules, and that we don't take certain meetings during certain times, that we have deep work times, that Fridays we do not do any meetings after 2 o'clock in the afternoon unless it's really important, or it's something that's like mission or operationally critical. We're trying to, in terms of the way that we think about how our organization operates, is to look at can we be a 4-day-a-week work week, because we do know that there is a lot of science coming out about improved productivity and improved mental and emotional performance of individuals that are working within the 4 days versus a 5-day work week. And so, we're trying to take a lot of the science and the research that has been coming forward over the last 4 to 5 years and apply it in the way that we show up in the world with the companies that we work with. And then they ask us, why can't we meet at this time? Or why is this off limits? And then we get to explain that, and we get to explain the science of that. And they go, oh, that's really wonderful and interesting. And then, of course, there's some tension that falls in line there to make sure we get the job done on time and within, the right milestones. But it's modeling really good behavior. So if you're a leader, if you're a manager, and you're not taking these things and doing them, it's not necessarily looking across to your employees and saying, you have to do this. That actually doesn't get people to change. What gets people to change is when you do it. And when you show people how it's done, and then when you tell people how you're doing it, people will pick that up. It's called a network effect. One next person will pick it up, and the next person will pick it up. It kind of sometimes turns into a bit of a telephone game. By the time you get to the fifth or sixth person, they're doing it a little bit differently, but they're actually doing it differently in the way that better works for them. And it's a really fun process to watch.
Thanks, David.
And I can add a little bit.
Amanda,
First, I love that approach where you're modeling the right behaviors. For us, we're such a large organization that really we've been having to change our approach depending on where we are, who we're talking to, but resounding across all of the organization is that leadership role. We're really lucky in that our CEO speaks openly about mental health and different challenges and has been very supportive of the programs that we've rolled out. But we've also had, we were talking about like the safe space for people to talk about their mental health. And so we have courageous conversations that are moderated, that have, we have positive mental health champions. These are the folks that are trained in our peer-to-peer network. And then we have these resiliency calls that are global that I don't think we realized how impactful they were going to be when we rolled them out, but we talk about topics that were emerging throughout the pandemic. And people are very vulnerable and they share, we've talked about suicide prevention, loneliness, resiliency, and all these different topics on what people sleep, what people happen to be struggling with. And people are very open with their challenges. And then the chat gets going where people are like, me too, I didn't know other people were feeling this way, and giving that safe space for people to talk and open up. And then we can get them the right resources. But we've been, you have to really try different methods for your organization, because what works for one group, maybe setting those clear boundaries, not taking calls when you say you're not going to on Friday, Saturday, Sunday. But, for others, it may be resourcing issues. So really just, listening to people to find out really what is the struggle within their group and within their location and within their region. But so that's, a couple things that we've been working on.
Thank you. So we've talked a little bit about how we're learning that a lot more employees are experiencing these things. How can we measure the impact that mental health or fatigue or burnout is having on employees? Are there any ways that you guys are working on that aspect of sort of understanding whether or not what the impact is in your particular workplaces, and then sort of whether or not the efforts are having an impact? And David, I'm going to start with you.
Yeah, so this is really interesting because it's a challenging thing to measure. Every response, and typically the way that you measure this is through individual surveys. And what gets challenging about that is everybody has their own observation, that is subjective. And so what might seem like burnout or fatigue or being really drawn down for me is going to look a little bit different for somebody else. But what's great is that gives us a great individualized view of where people are, and you can meet those people where they happen to be. What we tend to find, because this is really what we do, is we try to measure these quality of life aspects, is any company needs to commit to a measurement approach, and not just do it once. You have to do it multiple times, and you have to do it over and over again. And it has to be the same things, the same questions every time. So if, let's say, for example, you wanted to ask 3 questions about, do you feel, when you show up to work, are you rested? That's a really good question. Are you rested when you arrive to the office? On a scale of 1 to 5, how rested are you? Now, if you only ask that once, you're going to get just that one shot in time. You need to ask that you need to commit to asking that at some period, some interval over the course of a year so that you have some idea, because not everybody is going to respond to it. One of the things that we do know is that and organizations vary depending upon leadership and culture. But typically from about 40 to 60% response rates, you can get some really good information. But every time you do it, it's going to be a different group of people, right? I may not respond every single time. And so my big recommendation is start small, pick a couple of questions that you find really important. So let's say if it's burnout, don't necessarily ask about burnout, ask about how rested you are, or at the end of the day on a scale, if at the end of the day, here's a really good question. If you have a gas tank that's full at the start of the day, how full is your tank? And then at the end of the day, when you complete your work day or complete your work week, how empty is your tank? Right? So you got a before and an after, and then do that over and over and over again, multiple times a year. And then you got some comparison information. So keep it simple. Keep the questions kind of fun. If they're boring and sciencey and look like they came out of a textbook, no one's going to respond to them. So be fun about it. Mental health doesn't have to be all dark and gloom and doom. It can be fun. So fun questions, relevant to your culture, and start small. And the fourth one is commit to it for the course of a year. Oh, and there's one more thing. I want to just finish one more piece on that, because if you ask a bunch of questions of people and then you don't tell the people what their results are, then it was for naught. So collect the data, share the data, and share it again in a very fun way.
Thanks, David. Erica or Amanda, what are some ways that you guys are measuring mental health or the impact mental health is having at your organizations?
I can speak briefly. We have the 1 Million Lives application that Jacobs launched a few years ago, and then just did a revision that launched in October. And this is where you can go in and do a check-in, similar to what David was saying, where there's a short check-in or a long check-in, and you just talk about, answer questions on how you're feeling that day. And at the end, it gives you results. They've been simplified to a happy face, kind of a meh face, and then a sad face. And it links you to different resources. So, I struggle with sleep and perfectionism. And so when I go through and take my 1 Million Lives check-in, I'll go and say, okay, well, I need to focus on this a little bit more. We ask people to do these check-ins. It's anonymous. It's open to Jacobs and everybody. We didn't want it to be just a Jacobs tool. And so there's no identifying factors when you set up an account, but it allows you to go in. We want people to go in like regular checkups, like you would, when you go to the doctor. And so you can kind of gauge yourself and see how you're doing. And some of the results that we've been getting, again, they're very broad because we need to keep it as anonymous as possible. We can't gather a lot of the data, but we're able to see where people are really kind of struggling. And during the pandemic, we had at some of the younger generations that were struggling the most. They're improving in their mental health, but still kind of struggle. We found that Jacobs employees' mental health is continued to improve, where non-Jacobs employees may still be struggling or going down. So that was kind of an interesting fact to find. But really, it's about doing that check-in for your own personal needs to see, how am I doing? What, maybe I need to work on sleep again. Maybe I need to work on my perfectionism again, just as a reminder. But the data, it was kind of startling during the pandemic, especially the numbers on people that had suicidal thoughts. And it was much, much higher than all the data had shown us in the past, especially from like World Health Organization. So, we as a company put together extra training and, tried to get more resources out there. But really, since it's such a voluntary program, and we're not mandating people do surveys, we're not getting the whole population. So we're helping a little bit, but we'd love to be able to gather additional data where we could to reach our whole population.
Mhm. And I'll just add in just a couple things, 'cause I think, both David and Amanda had already shared a lot of wonderful aspects. And I'd say that MMA does a great job about surveying our employees. David, I love that you shared that you have maybe a few questions and you ask it multiple times throughout the year. We usually do a couple of surveys, workplace survey, which I still feel does have relation to mental health, as we're talking about our team dynamics, we're talking about how we work together. But then we also have a wellness survey, and I think it helps that we do focus on some other aspects, right? Like David was saying, keeping the questions fun, keeping them engaging. And so I think that we look at all the different pillars of well-being, and we do include questions about mental health in there. What resources would you like to see more of? What do you already enjoy using as a benefit as being an employee here? And then, of course, sharing the results. And I think both David and Amanda had talked about that. That people want to know, hey, you actually took the time to look at these, and here's what we saw. Here are the things we are going to work on as an organization. So I know transparency has already been discussed, but I feel like that is really key as well. Not only doing the measurement, but sharing that as an overall result.
Have you noticed, Erica, we'll start with you, whether or not some of these different topics like mental health or fatigue or burnout play out across different industries? Are you noticing any trends or differences or ways of dealing with it that need to change based on industry type?
Yeah, I think that some pieces yes, and other pieces no. Because I think that we want to have some consistent messaging, right? Regardless of industry, regardless of the person, we want to ensure everyone knows and understands. Again, what does it look like when someone's struggling? How would you approach someone? How could you connect somebody to a resource in the workplace? But I think it's the language. I think it's how we talk about it. And I know I touched on how maybe sometimes we have to compare it to physical health. We wouldn't ignore someone who had a broken bone, right? We would help them. We'd make sure that they got access to getting that medical professional. And we never hesitate there. But why do we hesitate so much when it comes to mental health? Because we know they're equally important. So it's understanding what stigmas they have. It's understanding maybe a little bit more about their culture, I think. I work with a couple of manufacturing groups, and I've learned, we have to find a different way to approach this. We have to ensure that we're reaching these team members in a way that makes sense. Um, so we aligned a lot of the mental health discussions to things they're already doing. They had a golf outing that they do as a team. So we talk about keeping your feelings in the fairway. How do we manage our emotions? What does that look like? So we're trying to tag on to things that they already enjoy doing, and making sure that we find the people who employees respect, and really follow. And sometimes those are just natural born leaders. It's not always that someone holds a title, but it's Joe who drives the truck, and a lot of employees admire him. He's been there for a long time. He might be the person that people go to for questions, or maybe he's just an open guy. And so it's understanding who are the team members, what role do they play, and then how can we really meet, the general population, because it can be hard, but we have to find those modes of communication too. If you have, toolbox talks, can we make sure that we're talking about how we can include the topic of safety as well as mental health? Um, I feel like, I saw a really staggering statistic around looking at the construction industry, and looking at construction falls versus construction suicide. And there was a blog by the CDC and NIOSH, and they had shown that on average, there's around 400 fall fatalities on construction sites every year. But on average, we're seeing around 4,000 suicides in the construction industry every year. Where are we putting our efforts? A lot of times, mostly into fall protection and safety, which is also very, very important. But if we don't talk about suicide, it only contributes stigma. And I think these co-panelists agree with that and hearing what they have shared. Again, with this manufacturing group, I talk about suicide a lot. And in September, with Suicide Prevention Week, they buy hats, they buy shirts that has the phone number on there. They've had community members ask to buy them. They've had family members reach out asking to buy them, but it started a trend. And so know that I've shared a lot here, but I think what's really important is that we understand that it can be different, but we have to find a similar way to get the message across.
Yeah, and I would just add to that one of the things that we see, and we typically are surveying people that are in the healthcare, mental and behavioral health space, and it's not so much who they care for or what industry they happen to be in. The number one determinant of a person's physical or mental health is their zip code. And we know that our location of where we live tends to drive largely our success in life and how we feel and how we move throughout the course of our day. And so zip code and where people live has been a thing that we tend to look at is if the organization or the population size is large enough or the community is large enough and there are multiple zip codes, we can actually start to see trends or differences. To Erica's point about suicide, a lot of that data in various communities is readily available from the CDC. And so we tend to bring those extra data sets in and layer that over in addition to, say, overdose deaths. And we can see, are there particular parts of a community where there is higher suicide, higher overdose, whether they're deaths or just overdoses, and what impact is that having as an externality, to speak in economics terms, an externality on individuals' health and well-being, because that external distress, we take that in. And whether you're the biggest or burliest construction worker and are hardened and tough, these things wear away at us over time, and we bring those things in to our life. And so I think it's really important as leaders to also think about geography. Where do my people live? Where are there places in my community that might need additional help or support? Because maybe it's a food desert. Maybe the people where most of my employees live, there's not a grocery store within 2 miles, and they can't get good, nutritious food. Now, is that my problem to solve as a CEO of an organization globally? Probably not. But if we're thinking globally about the people that we serve, I think these are some important questions to ask, because if I'm not eating the right food, if I can't make good decisions, if I'm not putting the right fuel inside of me. And so I think we can kind of start to move around the edges a little bit, because sometimes, we talk about burnout and fatigue. One thing that we've learned over the last couple of years is a lot of people are really fatigued about the conversation of mental health. And so we have to think about various ways that we can have the conversation without having the conversation. And so maybe this will kind of spur us how to do that. We're really diving right onto the head of a needle here, which I think is really important. But as we have these conversations, it's important to think about how do we talk about mental health without talking about mental health?
And I'd say what we're finding is very similar to what both Erica and David mentioned. We do have, our business does span across industries. So we, unfortunately, our construction programs and our operations and maintenance field employees do have a higher suicide rate. And this was something that was actually identified before we went into the pandemic. So that part of our population has always really focused quite a bit more on our Mental Health Matters program and suicide prevention, getting the discussion started. But we've also found that when we reach out to have discussions with people, it's where they identify themselves. And so we have a lot of employee networks. And we have different discussions within those networks to support the needs. So Women's Network, PRISM Network, VetNet, so our veterans, our employees with disabilities. So we have different champions dedicated to each one of those networks, and to provide the different levels of support and have different discussions, because the mental health needs within some of these parts of our population can be very different on what people are struggling with and what to focus on. So not only is it the type of industry, but it's where the employee is, and what group they identify with the most. So we've been able to make some strides there with a little bit more targeted information, which I think has been helpful.
So we've talked a little bit about this issue of stigma, but I wonder if we can drill down a little bit more around sort of the stigma around mental health and how the pandemic has maybe shown a light on some of the different mental health issues that people are experiencing. Is there anything that you guys have done in particular specifically around that stigma?
I can start. I really do think, we covered some of it before, but really it's getting, opening the door for the discussions, having your leaders speak openly about mental health, mental illness, the different challenges people may have, and then showing their support for their employees, because we still we're still struggling with the stigma part. People aren't comfortable getting a hold of the employee assistance program because they don't feel like it's truly confidential. They don't want to reach out to HR because, again, there's this stigma around, oh, maybe these are the people that hire and fire, and maybe I'll have a little sticker on my file that says, this person struggles with mental health issues. So the more we can educate people and get those conversations, like I said, the courageous conversations, just opening up the dialogue at all levels of the organization, but having it start at the top to know that there's support for our employees and all the additional programs we put in place. But really, until you can just keep letting people know it's okay, training your employees what to look for, how to have these conversations, because they can be awkward sometimes. Not everybody's a natural talker, and not necessarily the person you'd go to if you're struggling. So having the right people in those positions to talk and present at meetings, we call them culture of caring moments. They started from our safety moments, just to have those discussions and get the information out there that it's more normal than people think. We used to hide the fact that people had anxiety, depression, addiction. And when people can start talking about it, and, if I was to open up about, some part of my life, then maybe somebody else would feel comfortable doing the same thing. So really just getting people talking about it, that it's okay, has been the biggest step. But we still struggle. We really do.
Yeah, and we see leaders and managers in particular really feel that stigma a little bit harder. Like they really don't feel like they can step forward in that space. That seems to take a little bit longer. One of the things that we do to help train some of the folks that we work with, and again, we're working for a large part in the space of people who care for these folks, is if you really want to signal your comfort level, is to, if you have shared calendars within your organization, is to label your calendar event as therapy or mental health, and you're going to be out of the office for an hour. And when other people are able to see that calendar event, that it's you and you're not in the office because you're going to therapy, that's really quite something. And that sends a bright, shining light to the rest of the organization, or at least those that have that visibility, to say, oh, David is going to be gone for the next 2 hours. He's not going to the gym. He's going to the mental health gym. He's going to the mental gym. So, a lot of people will put, going to the gym over lunch, and nobody thinks twice of it. They're going to work on their physical self. So why not set your calendar to say, I'm out for the rest of the day because I'm going to the therapist. And that will really shake up a culture a little bit. We've actually seen that get to a point where it was like, ooh, I don't think I want to know that. But it requires a lot of vulnerability and a lot of strength for some people to set that tone.
Erica, did you have anything that you wanted to add to that? Did we lose you, Erica? So what are some of the other challenges? Oh, there you are. Oh, she's
As a
gone.
mental health first aid instructor, I've had the opportunity. Yeah, are you able to hear me okay?
Nope, you're cutting in and out on us, Erica. All right. So I think we'll just wait for her to come back to us. So I think one of the things that we've talked about a little bit is, stigma and mental health, and kind of bringing things out of the closet, out of the shadows. One of the topics that's sort of sweeping around social media is this idea of quiet quitting or people being less engaged. How do you feel that that plays out in some of these discussions, versus what's happening sort of publicly or social media wise, and sort of what's happening at our workplaces?
I can kick it off. So I found it to be such an interesting perspective, because when you hear about it, especially social media, there's the two sides of it. There's the employer side that's often, well, nobody wants to work. Everybody's just doing the bare minimum. And then there's the employee side, which is I'm doing the work that I'm paid to do. I'm supposed to work 8 to 5, and I'm working 8 to 5. I'm getting all my work done, but I'm not doing above and beyond. I'm not working my nights. I'm not working my weekends, which really was the norm for a long time. And in some organizations, in some fields, it's expected. So we say that, you're working 40 hours a week, but the expectation's 50 or 60. And so I think what this has really done is just open the dialogue to what is the real expectation for my job. Because I'll do it, but I also need to have this balance and have a bit of my life back. And I think that's something that really became obvious during the pandemic, when we had no lines. You'd get up in the morning, log in, right? You wouldn't go anywhere else for work, a lot of us. And so we struggled quite a bit drawing those lines. I'd start at 6 and then, do the kids stuff, but then just keep going and going and going because I'm working in my home. So it took a while for people to figure out how to do that, and then realize how important their home life was and draw those barriers. And so I feel like people weren't necessarily having good discussions with their supervisors or with their employers to say, okay, what is the real expectation? I know a lot of people had decided, well, align that with my pay. And that's a challenging discussion too, but just to be able to maintain your mental health. So as somebody that focuses on that for our employees, I encourage those discussions. Make sure that the employer has a good understanding of what it really takes to resource a task or a project, because before we were just doing the 60 hours and maybe they didn't know that. So now if it's going to take 40 hours and this is what I get paid, I'm going to take the rest of my time for myself. And then that makes it so that the employer can properly resource. And it's a different mindset. Again, it's just such a negative side, the way the quiet quitting phrase from the employer standpoint of, you're just not working anymore. Well, you are. You're doing what you're getting paid to do. And so it's been an interesting discussion and kind of debate. Within our organization, it's really started good conversations about resourcing and about insisting people take their time for themselves as well. So.
Yeah, and I would say, as somebody who's written my fair share of job descriptions, this is a great opportunity for companies to really get focused on the roles that they have within their companies and the descriptions that they write and where that job lies. and what you're responsible for. Because people are going to go back to that. If they're smart, they're going to go back to their job description. And if it's, ambiguous or, says more than it's supposed to, then that's tricky. So, people will, like, Amanda said, people will work to what they're getting paid to do and what might be in that job description. And so, I'm a lawyer and I'm not your lawyer and I'm not an HR person in particular. But what my job description says is typically why I showed up. Or there might be other things too, and I'm gonna step up to do those things. But what are people there to do? And typically it shows up in the job description. So write those in a very meaningful way.
Erica, you're back? Oh. Nope, I guess not. Okay. So one of the other questions that we had, oh, there's Erica. Erica, are you back? Can you hear us? Oh, she might be frozen. So one of the other questions that we had was whether or not any of you had noticed any sort of global workforce differences or any sort of lessons globally related to any of these topics around mental health, fatigue, burnout, quiet quitting, some of the things that we've been talking about here. Has anyone had any experience or expertise or knowledge around sort of what's been happening globally? And Amanda, I'm going to start with you.
Okay. For our Mental Health Matters program, just starting with that, rolling that program out, because we are a global organization, that actually started in Europe and expanded to our Australian population pretty easily, because the discussion was something that came a little bit more easily in those locations. When trying to roll out the program in other locations, you need to really think about culturally what you're allowed to say, what you shouldn't say. So when we rolled things out in the Middle East, it was a slightly different program. But to be honest, where they really struggled was kicking it off in the US, because what we struggled with the most was we're such a litigious society, and our legal and our HR departments were really concerned about having these open discussions. Would we be opening ourselves up to some sort of litigation? Because people hadn't been talking openly about suicide and, how are you feeling and what your mental health issues. It was just so taboo to have those discussions outside of HR that the program is still a few years behind here in the US for Jacobs. And I feel we're pretty advanced in the mental health space, but still, we had a steering committee discussion within our organization recently, and looking at the numbers and where people are connecting and what people will utilize for our employee assistance program. And then some anecdotal stuff about just, who's comfortable speaking about mental health. We're a little bit behind, our global partners within Jacobs anyway. So it was kind of surprising to see that we were still, a couple years behind everybody else. Although I do feel like we're making advancements. People are just still feel it's taboo even asking those questions and getting into people's personal lives a little bit too much. That's what they feel, instead of just showing that we're asking these questions because we care and we want to take care of our employees. So when we do these surveys, they are confidential. Nobody believes it. And so we really just struggle with getting the information where other parts of our organization will just openly speak about what the challenges are and where we need more resources. Here, people just don't want to raise their hand and say, I struggle, and this is what I'm struggling with. So I'm hoping that, the continued discussions and giving people additional resources, again, the confidentiality part, just getting the information out there that it really is truly confidential, but different avenues to get the resources that they need and the help. But honestly, globally, it's, I feel bad that here in the States, we're the ones that are kind of lagging behind, but that's just what we found.
Yeah, what I would add to that is in the United States, we typically see that one of the top places that people go for comfort is happy hours and socializing around alcohol as a place to diffuse some of their stress. And lately, especially in the last year, we have started to get requests from companies around the world who are really trying to shake up their organization or their community's relationship to alcohol in particular. And because what we measure is kind of the underlying factors of stress in people's lives or quality of life, the determinants that lead to a person being resilient or anti-fragile. They're really curious of how do you do that? How do you do that sort of alongside this culture where alcohol is really shifting in prominence in people's lives? Another thing that we see too is younger generations, both in the United States and around the world, are actually consuming less alcohol. That is opening up other avenues for different ways that they cope with things that haven't been trained in terms of emotional coping. Because my generation and older, it was very easy to just go have a couple of beers and that's how I'm going to cope with a hard day. There's a lot more technology involved now, and so we see globally that the way people use their digital devices and phones and how those are coming into work environments in different places is really changing the dynamic of the way that we think. How do people de-stress, and what does that mean in terms of different countries and different cultures, and what should we be keeping our pulse on? But I do find the changing nature and the way that alcohol's prominence in the world is really starting to shift a lot, and I think we should pay attention to that and be smart about that and leverage sort of these new places of sober curiosity and bring that into how we engage as a company.
Erica, are you back? Can you hear us?
You are all the best. I could hear you all the whole time, but obviously my end was not working well. I can commit to, if there's ever any questions and you lose me, please feel free to take those and I'd be happy to address them via email. But just kind of taking on to this, I know we're kind of talking here about some of the global aspects. And I think, something that's interesting is that mental health first aid is a class that I facilitate, but it is available across many countries. And I feel like they've done a pretty good job of relating that to different cultures and ensuring that it speaks to the variety of aspects and accessibility to resources. So I would say that, I think, I was catching on to some of the other things the other two had said, and we have a lot of work to do in the US. I think we see a lot of other countries a little bit more advanced and have a lot more resources sometimes in this space. So I feel like, we're seeing more and more coming out. And I think it is important to think about culture and social support. And, as David had talked a lot about, some of those social determinants of health and how that can be different as well.
Thank you. So one of the things that we've talked a lot about is sort of the culture, the having safe spaces for people to be willing to talk. But we haven't talked a little bit about whether or not some of those efforts have translated into policies. So if you guys could talk a little bit more about sort of what organizations can do as far as turning some of those efforts into policies to help sort of protect employees or make employees feel a little bit safer in that space when there's also policies tied to it. So maybe Amanda, do you want to start?
So we actually have not developed a significant number of policies surrounding some of the safe spaces and the conversations that we have. We've just set up the framework for being able to enable those within our networks, because we keep them with leadership support and engagement. But what really helps with those conversations is that they're unscripted, they're vulnerable, they allow employees to be there without guiding policies other than, respect for each other kind of things. So those are the the calls that, like I said, the resiliency calls that we have and the courageous conversations that are hosted within the organization by our employee networks and then our positive mental health champions. As far as other programs we're initiating in the HR realm, those typically are just our benefits related information, just expanding that type of information and just understanding that it's different everywhere that we are, as our international benefits versus our US based benefits, to ensure that people are getting the benefits that they need. So not a lot of formal policy at this point. Oh, but there is one that's changed. They are changing paid time off. And so that is something that has been morphing into a different kind of policy to ensure that people get the time off that they do need. That's the biggest one, and it hasn't quite, it rolls out next month. So I'm curious to see how that works, but that's really just to help ensure that people get the time off that they need, that not everybody was necessarily taking. So that's the only hard policy that we've changed, but everything else is more aligned with just giving people more opportunities.
Erica, any policies?
Yeah. Sorry, go ahead.
Nope, you.
Okay. I would speak from a client perspective. I think that we've been seeing more HR teams, managers, supervisors have these conversations about policy and procedure, because you have a lot of these already in the safety space. You have a lot of these already in the physical health space. But what do you do? What do you say? What's our process? And while I'm not seeing it as necessarily a common conversation, I do see it more often than I had in the past. I have a client that has a specific process of what to do when there's a suicidal employee. They talk about, you can come to HR. We are there to support you. This organization has all of their leaders, managers, supervisors trained in mental health first aid. So they have that certification, but they have built this policy about, here are the resources we have. We're not expecting you to be counselors. We're not expecting you to be therapists, but what we hope you can do is be the bridge to care. So you're the person who's first there to support someone, and to guide them maybe to the next step. And it's important that we have those boundaries. So I think it's a lot to do with internal training, having those partnerships, having managers, leaders go through mental health first aid, QPR, which is specifically about suicide. Getting further training, I think, goes hand in hand with policy, because we can put in a policy, but if people aren't trained on it or they don't have the education to put it into action, there's a lack of understanding. And so I think that we're starting to see it more, which is a great thing. I'd love to see more of it.
So David, unfortunately, jump off, but
go ahead.
Sorry, Amanda, go. I was just saying David had to jump off, unfortunately, but you can continue. Sorry, Amanda.
Okay, sorry about that. No, I was just going to agree with what Erica said. Our positive mental health champion training is based on mental health first aid, because it does have that ability to be global. But we have guidelines more than policies. So when, as she was saying, if there's an employee that's suicidal or somebody that needs additional resources, it's all about signposting, because we're not training our employees to be clinicians. They're a listening ear, and then they know where within our systems to help get people the resources, whether it's, the employee assistance program, maybe it's a special type of leave that somebody may need. And I saw there was a question about forms of harassment. That's where we do have policy. It's our code of conduct within Jacobs. And so as a trained champion, if I'm listening to somebody and, what they're telling me, just as, I'm a listening ear, but then I clue in that maybe what they're talking about is something that's against our code of conduct, like harassment, retaliation, any of those things that there is an actual policy. Our employees are trained to say, well, this is what it sounds like. is happening here. We need to take this to a different level. This needs to go to HR. There is actually policy around, workplace harassment. And so having employees and supervisors and everybody trained in this just really helps the discussion to, because we don't want our employees put in an awkward position as a volunteer of a peer-to-peer network when you start crossing those lines into something that is breaking a serious policy. So having people trained and having that understanding is really helpful for, beyond a guideline.
So I think we have a couple of questions from our audience. So the first question is whether or not we'll provide some resources on what each of your organizations provide. I think that's probably something we should be able to do. Do you have specific links or anything that you wanted to call out?
And I can provide the information for our 1 Million Lives. Again, that's a free resource for everybody. And so, there's a lot of information out there, but that it's really a great program. We've had 40,000 people check in. And so it's been something where we think there is impact, but it's what the person needs. 1 Million Lives may work for you. It might be a different app for somebody else. So I can definitely get that information. Actually, Stephanie already has that, or I can put it in a chat.
Perfect. So anybody can email safer@nsc.org. So SAFER@nsc.org. And we can connect you with some resources as well. I think we had one other question. I don't know if we got to it or not, but is there any data on this topic as it relates to harassment? And do people feel demands of work as harassment as a form of mental health or stress?
I personally do not have an initial response to that question, but I think it's really important, and I can see how those two go hand in hand, but I don't have any data to share right off the top of my head.
And I don't have any data on that as well.
I don't either. So I think, are there any other questions? Okay. Otherwise, I thank everybody for coming to this really important panel topic, and I urge everyone to follow up with Safer if you have any other questions or information that you'd like from us. Please be safe and be well. Thank you.
Great. Thank you, Rebecca and Amanda, Erica, and David. We appreciate you taking the time out to share those valuable insights. By no means, again, while a great hour and a half or an hour and 15 minutes worth of discussion, certainly no fatigue, built up in that one. Just to kind of connect some of the dots from today's earlier discussions, as Pan Am was concluding their 95-year history, I too was concluding 4 years of my Latin education in high school. And after 4 years, only two words stood out: cura personalis. Right? I think that's really germane for those of you that don't know what that is. It's talking about the care of the whole person. And so something that really resonates with me and really is something that's driven my life's work. And I suspect it drives the life's work of all those that we've heard today and those that have really entered the EHS profession. One of the questions that was talked about earlier was, well, that's HR's issue, and we shouldn't have to deal with mental health as EHS professionals. We heard Malcolm talk about start from a position of empathy, right? Those are ways that we can be the, as Erica mentioned, right? We can be the bridge to care. We don't have to. We're not clinicians. We're not therapists, and no one expects us to be. But what we can be is we can be a listening ear. We can be the bridge to care. We can be the person that says, "Are you okay?" We can make those questions in any sort of way that we so choose. But it's coming from that position of care, that position of empathy, the position of just being there, being the go-to person, as Erica and Gus mentioned earlier. Again, those are the type of people that are going to help us get the entire workforce, right? Not just those people struggling, but the entire workforce. It's going to help us collaborate and really congeal our mental health efforts and, again, in our physical health efforts as we move those programs forward within our organization. So on that note, again, I'd like to take a moment to thank and give a round of applause for all the panelists that we've had today. You're on mute and your video camera is off. So whether you're doing a golf clap or the icky shuffle, celebrating whichever way you feel most appropriate to thank our panelists and those that helped us out here today. Again, John and Rebecca, great curation of panel discussions today. Richard and Malcolm, also great presentations. And again, we initially heard from Caitlin and Caitlin from the Safer team and Lorraine again with an overarching welcome message today. We had a great group of practitioners, thinkers, and leaders, and we had it on our virtual stage today, and we're going to do the exact same thing tomorrow. Dialogue's been rich and informative, hopefully, and hopefully it's not been an infodemic as Travis mentioned, but hopefully again you're not super saturated. And if you are, again, maybe your tank is empty, but certainly your mind should be full of information that you gathered here today. Greatly appreciate what you've contributed to today's event. Another thank you goes for all those registering for the event. Those of you that have stuck around for the closing comments here, again, participating in today's discussions. And thank you for those of you that have put your questions in the chat. We were able to get to most of those today. Again, looking forward to your participation again tomorrow. Hope you're able to gain some insights from the various topics that we had today, and look forward again to bringing them back to you tomorrow. And hopefully, again, you've got some things you can take away, whether it be this afternoon or tomorrow or later this week. Hopefully, you've got some things that you can take back to your organization. As was highlighted earlier, it might be in the chat or again, if you've got questions about looking for resources that you want to bring back that you heard discussed today or unsure of things that you may have heard mentioned, certainly you can email safer@nsc.org. That's SAFER at nsc.org. And all that is brought to you by, her name is not on the script here, but I'm going to embarrass her virtually anyways. Stephanie Roberts here has done an exceptional job. Kind of classically, without her, there is no me. There's no any of this without Stephanie's dedicated efforts and again, in putting this exceptional summit together. We got another day going in tomorrow, but and we look forward again to your participation. So, again, as we close today, the two overwhelming things that I heard today were trust, and communication. Talking about communicating in a way that's clear, that's receptive to the employees. There are tons of resources. Companies have invested, we heard earlier, billions, if not more, dollars in whether it be the mental health of, the physical health of, the well-being of our employees. And we want to make sure that they are in fact aware of what those are. So we want to make sure that we are communicating those in a way that is not just sent from the communicator, but it's received by those that are in need of those services most. So again, start from a place of empathy, communicate with truth, and really approach those individuals and do everything that you can to help meet them where they are. Before we go and reconvene tomorrow, I'd like to make a few other notes, administrative in nature, on the next steps. First and foremost, encourage your feedback on the event through our exit survey, which will be automatically forwarded to you after the event tomorrow. You'll also receive an email next week with a link to this survey and a wealth of additional resources on the topics from the National Safety Council. I'd also like to remind you of the recent SAFER report that was published in September, which covers topics like worker health, vaccines, vaccine requirements, and more. You can access the report by going to nsc.org/safer and clicking on the report tab. I want to also encourage you to sign up for NSC's upcoming event, The Future of EHS, which will take place January 31st to February 2nd in Long Beach, California. To register for the event, please visit nsc.org/future of EHS, FUTUREOF-EHS. Tomorrow, you'll be able to access the event again, which goes from 9 a.m. to 1:30 p.m. Central Time, where you'll hear from more subject matter experts, EHS professionals, and more about long COVID, resiliency, and crisis management, and hybrid work and workplace culture. With that, thank you again for your active participation and engagement, and have a wonderful rest of your day. For you, for me, for all of us, we look forward to seeing you again tomorrow.